Okay. To some degree, I want to say now for something completely different. I'm going to talk about all sorts of little acronym-y things here, but let's get into the meat of what's going on here. So I'm going to talk about instruments, and indeed, over the next half hour or so, I'm probably going to introduce 200 possible instruments which you could, in theory, use in research oriented in validating, or I'm going to show some other reasons why you'd want access to these instruments. So, but again, why do you care about this? I'm not going to show therapy. I'm not going to show outcomes. I have plenty of research kinds of papers, but I'm going to go straight to talking about really three things. Why do you care about standardized measures? One is you want to prove that an intervention has an effect, and there's been as I believe almost every speaker has talked about earlier today, at least certainly in the morning session, that it's difficult to prove in a classic research sense that some of the therapies and some of the interventions you're talking about have a lasting effect. And so we can use different types of measurement systems to prove that. And when I saw some earlier presentations today demonstrating it's difficult to do that sometime, what pops into my mind is, assuming there is an effect, and I generally assume there is, then we're looking at the wrong outcome measure. And may very well be the measure, and I'm going to show you how there may be different measures you should be looking at in order to make the case. But there are other reasons to use measures. One is to describe the characteristics of your participants, and very often you're dealing with different groups, and there may be differences you don't recognize. You know that you got a person from this group or this group, or they have this diagnosis or that diagnosis, but very frequently underlying you have a different level of depression. I do a lot of work with surgery boards. They're very frustrated. The x-ray looks perfect after the surgery. One patient is happy, one patient's upset. I ask, what's their level of depression, irregardless of the disease, and what's their level of social support available? And guess what? Very often the patients who are upset with the identical surgery, they were depressed going in, they're depressed going out. And if they show back up in the emergency room, almost completely predicted or highly predicted by, do they have home social support systems? A person living at home who's elderly, is having trouble post-surgery, is just going to go back to the emergency room. And under new reimbursement guidelines, that hospital's going to spend a lot of money to help them, versus if they're somewhere where they have a support system at home, then they're going to much more likely to be able to self-resolve. These are things we can measure we have measurements that can point to this, and you can be tracking this along with the study. And again, that also has some why interventions work differently for some participants. You can see it's working here, not there. There's something else going on. Perhaps there's a measurement system that can help figure that out for you. So I'm going to actually talk about three measurement systems, and these systems are all sponsored by various institutes within the NIH, represent collectively about $175 million of development dollars. But you're going to see why that, I believe, is a worthwhile investment. First is PROMIS, and these are the next three slides are what was the goal set out by the NIH for each of these systems. And you can see PROMIS was to create a large system of patient-reported outcome measures. I'm probably going to slip into using the acronym PRO. And that's where a patient is telling you something about themselves. It's a self-report mechanism. We saw from DARPA, you can get at some of these things perhaps through electronic methods, and certainly Nina's work with brain waves, you can get at some things, but what's the fastest, quickest way to get at these things is a patient-reported outcome measure. And the goal of PROMIS was come up with outcome measures that are consistent, that can be used across studies. We can come up with computer-adaptive testing. We'll talk a little bit in a moment why that's important, and make them publicly and cheaply available to people. NIH Toolbox. Look at this. If you read between the lines, almost the same, except here we're looking at more objective measures, cognitive, emotional, motor, and sensory. Again, common currency across many different designs and populations. Now you're going to see out there, and you've seen yourselves, that there's the XYZ instrument to be used in music therapy with traumatic brain injury. Well, that sounds good, and maybe there's no such instrument, to the best of my knowledge, but even if it existed, it turns out that a large number of patients have different diseases, and so using an outcome measure completely focused on a single disease can be problematic. So really, the more we can use common measures across diseases, better. I'll talk about that a little bit more. And how do you get yield from large, expensive studies? A lot of instruments that are out there today, developed, ironically, initially in the public sector, then moved in the private sector, are so expensive, research studies can't afford to use them. And finally, Neuro-QoL. Neuro-QoL is similar patient-reported outcome measures, really dedicated to a neurological disease audience, or neurological disease patients. Core questions, universal with chronic neurological diseases. It's kind of the opposite of the other two systems. It's saying, yes, indeed, in neurological diseases, we need some things that are more specialized. And look at that. You can see all these date back about a decade. So clinician researchers, we went out and surveyed what do researchers want? And they want things psychometrically sound. Psychometric is almost certainly a strange sounding word, but basically it just means, do the instruments actually measure what they're supposed to? Do they have statistics behind them? And I feel your pain if you have an intervention you've developed, you're positive it's going to work, you've shown it in a small group of people. I have the same standard in developing an instrument. Okay? I can't just put it out there and say this measures that. Now, by the way, I could. That's the irony, right? I can create an instrument I can put on the internet and people will start using it. I can create an iPad app overnight, sell 100,000 copies. That doesn't mean it works. Okay? I have to go to tens of thousands of patients in different diseases and to prove the case that this instrument can be used and will make a difference. I want it to be brief and easy to use. You can get a great neuropsych consult for about 3 days of time, and I'm sure your patients showing up for a half-hour session or hour session once a week are just not going to volunteer to go a 3-hour session, get something done. So we need it fast. You want the assessment you're doing to be less time-consuming than the intervention. The concept of intellectual property free is there's a pretty nice history in the United States of somebody creating a measure and then it costs people a lot of money. And that doesn't help the research effort because you're already constrained. So can we get measures that are free or close to free? I'll get into that a little bit. Variety of settings. I don't want it to be in a lab setting. I want to send someone to the doctor's office. I want to do it where I'm giving therapy. I want to be able to give it in the home. I want to be able to give it remotely, different groups. And then available in multiple languages. There are a large number of people, certainly in this country alone, that primary language is not English. So if the instrument you're using is only available in English, you just knocked out a fairly significant number of people that you're talking to. And we need the full range of a trait. Ooh, okay, what's a trait? A trait's whatever we're measuring to some degree. It's the depression, okay? It's fatigue. It's hearing. And the things called floor and ceiling effects, which may be things you've never heard about, but this is what keeps me up at night. We all have things that keep me up at night. And it turns out that a lot of instruments have a floor or ceiling effect, and that means the instrument that you think is measuring what you want it to measure, if it has a floor effect, it doesn't go low enough. It just doesn't matter that you're trying to reduce something. Your instrument doesn't go low enough. And while you've actually reduced the person's whatever problem it is, your instrument doesn't measure that. And the same thing at a ceiling effect. Ceiling effects I've been doing the last couple of weeks has to do with physical functioning. Most measures people use to assess physical functioning really accurately assess people to about the mean of the population, right? Because that's where an insurance company wants to pay. If you can walk around the block, we've cured you. Well, that works except if you're a person who likes to jog, run, involved in sports. But guess what? There are very few instruments that accurately assess people at that higher end. Also available across the age span. Been working on the National Children's Study, which is leaving us, worked with the old, but very few instruments span that distance. So if you're doing research that spans ages, you're currently forced to use instruments that are different, and the scores aren't comparable. So to the extent we can find instruments that can be used at any age level, the better. So again, all these NIH systems, same instruments for many diseases, same scale, so the number systems you're using don't look different. Well, this is a -6 here, and this is a -45. Well, it turns out the -6 is better than the -45. It's hard to keep track. And that sometimes we can come up with different kinds of instruments. Single items, short forms, long forms, something called computer adaptive tests, which hopefully we'll have time to do, look at. We want a score that's the same regardless of the kind of test that we give. But most legacy measures fail to make the grade. A legacy measure is the measure everybody uses. Okay, very often the legacy measure is the one you learned in school or someone learned in residency. And guess what? Psychometrically sound, not always. There's an amazing number of instruments which we use and are in the literature, never use them. They were never proved that they worked. Never, ever, ever, ever. There's no, go back and look at the literature. When they were released, nobody ever showed they worked. They just look good. Brief and easy to use, really rarely, right? We use instruments. We saw a lot of sessions of an hour therapy this morning. The measures you're going to give people are 3 hours. It just doesn't add up. Intellectual property free, again, not always. Applicable in a variety of settings, sometimes, but very often you need to do it exactly in a soundproof room for hearing. It's a problem with hearing. The best hearing goes in a very expensive room and things like that. Different subgroups, rarely available multiple languages, again, sometimes. And by the way, sometimes when they're available in multiple languages, the scores don't mean the same thing. So you've got the score, this person improved on the English version, this person didn't improve on the Spanish version, it turns out they did, it's just the numbers are different. Okay, neither can most legacy measures cover the full range of a trait. We talked about the dangers that I'm going to show you. Again, no floor effects, sometimes no ceiling effects, almost never. I'm really aware of very few instruments that can measure the top. You can rarely take a person we'll call gifted hearing and are measuring them on the instrument you've been using across the age span. Many diseases, rarely, we're going to get in that 1 second. Same applicable to instrument diseases, never, and all sorts of other problems. So here's my favorite ceiling effect slide. This is PROMIS, Patient-Reported Outcomes Measurement Information System, anger. So we're testing anger against the mask. So the nice thing with a PROMIS anger CAT, it takes on average 5 or 6 items to give. Okay, so we're actually able to get a clinically reliable measure of anger in 5 or 6 items. And actually, my next paper says 4, but we'll worry about that later. And here's a study. These people were in therapy. It wasn't complementary therapy, alternative therapy, but they were in classic psychiatric therapy, baseline. After 1 month, both instruments detected a nice change. The therapy did a great job after 1 month. After 2 months, the classic instrument to assess anger showed no improvement. Okay, that's a flat line. So I look at this study, the published research would show quit after 1 month, right? There's no benefit. The PROMIS instrument showed the effect more than doubled after 3 instruments. It's a ceiling effect. The mask simply couldn't detect that the intervention was helping a person. It had nothing to do with the quality of your intervention. It had to do with the instrument you were using to measure it. The reason the CAT was able to pick this up is the CAT's able to zero in at different levels of the trait. And most instruments we use are generalized functioning. If it's a physical functioning instrument, we ask every single patient, do you have trouble getting out of bed? Or you have trouble running an errand? Can you walk around the block? We're done. We ask everybody that. We ask that to people who are bedbound. We ask them all about how they're able to walk, right? And we don't bother asking above walking around the block again. So what's the problem with disease-specific instruments? I nicely stole the slide, except I credited them at least, so that was good, from Medicare. And they showed this at a PCORI meeting at the Patient-Centered Outcomes Research Institute. It's a group that's funded currently about $500 million a year to explore patient-centered outcomes work. And you can see of the people seen by Medicare beneficiaries, only 32% of the people have 0 or 1 disease. Everybody else has more than 1. So if I'm going to assess fatigue in this group, does that mean the group up here on the right gets 6 different fatigue measures? Fatigue for TBI, fatigue for depression, fatigue. It's not practical. And I assure you, your patients won't do it. So we need measures when we can that can be used across diseases. And again, average functioning just doesn't work. I'm saying we can show that, we can show we brought a person to average. It makes sense to us. We might get our research funded, okay? But a physically active patient, Tripp's going to be talking about people in the military. When these people are done and they've been brought back and they're getting treatment, a lot of them want to go back out in the field. They can't be average. They have to demonstrate that they're at a very high level of functioning. That applies to athletes. That applies to hearing. When a person's got a hearing issue, trying to remediate it, a person doesn't want to go to average hearing if they had above average hearing before. A musician doesn't want to know, oh, you can now hear conversations in the room. They want to be able to hear the tonality they need to play their instrument. And a cancer patient, it may be nice that they got their fatigue to average, but they want to get back to being able to be an active person they were before. So all the measurement systems I'm talking about are intellectual property free, psychometrically sound, scores are scaled, so it doesn't matter what you give them on brief, etc. Here, I'm going to zoom ahead. So the promise of NIH instruments, comparable across multiple studies. My favorite anecdote is when I got into, I've been in measurement my whole life, but I got into patient-reported outcome measurement about 15 years ago. I went to my first conference, International Society of Quality of Life, all these measurement nerd types sitting around. They're talking about fatigue. I looked through the program, 40 presentations on fatigue in this disease and that disease, 40 NIH-sponsored studies, 48 different NIH-sponsored measures of fatigue. Guess what? Even if they're all great, they're not comparable. Can't tell. So I've got two drugs, use two different measures. I don't really know which one's better. They both proved their point, and by the way, I'm assuming they did, but they weren't comparable. Okay, reliability, reduced response burden, being highly reliable. Again, make these instruments short so you can learn more things, improve precision, and tend to use computer-based administration because it helps us immediately score, immediately report. When possible, we try to lean towards something called computerized adaptive testing. It's sound, it's short, it's targeted to use a computerized algorithm. This is way different than you thought you were going to wake up and hear this morning, but let's go for it. Who uses this silly thing? The Army. By the way, the Army did this starting 20 some odd years ago when they had the Armed Services Vocational Aptitude Battery, and this is a test given over 1 million high school students a year to see if they're applicable for going into the armed services. They're giving these very long tests to high school students. So there are two problems with that. They're too long, and actually they were actually easy to cheat on because you took it and you told your friend all the answers. So they wanted to give a computer-based test. It's the same problem that actually the graduate record exams given this way, security dealers, nurses. Using adaptive testing, we're able to take 12 hours of testing down to 2 hours for aptitude testing. And for emotional health measures, we're able to take a 90 or 100 item survey down to 5. Same reliability. So what is it? On a simple example, I've had a pass-fail test, and we don't have that really for fatigue, but it's an easy example anyway. We give a question, and we have a trait range, right? We have, how do I do this without getting this in my eyes? Very good. Okay, so we have a trait, low to high. Doesn't really matter what it is. I do a lot of surgery boards, I do educational tests. But so if I'm giving a first question to somebody, I put it somewhere near the middle. If it's a pass-fail test, I give them a question near that range. They get that correct. It's a happy experience. So I give them a harder question. Get that wrong. Give them an easier question. Get that right. A little harder question. They get that right. They pass. Why do they pass? Well, I just missed giving them a case of osteopathic surgeons 1,800 items to pass their certification test, by the way. Since they can pass items here, why would I give them these items? Since they can already walk around the block, why would I spend half my time with them asking about how hard it is to get out of bed or how hard it is to walk across the room? I know they're here. And as soon as I ask them a question, can you run a mile, and they get that wrong, why do I ask them about running 5 miles or 10 miles or 15 miles? Well, a lot of smiles in the room, but that's what most of our measures do. So the adaptive test zeroes in. And while on one hand, this seems ridiculous, did I just pass someone in 4 items? And I help people with surgery board exams. I assure you they don't want to be passed in 4 items. They want to know that they're 20-some years of education. I actually know this person's going to pass. It doesn't matter if I give them 5 items, 50 items, 100 items. They're there. They know enough content to do that. I'm about to show you a slightly sadder situation. Person does not pass an item. At the pass point, we give them an easier item. They don't pass that one either. Give them an easier item. Thank goodness they know something, but it's probably multiple choice, so who knows what they really know. And we give them a little harder, and they get it wrong. Now, by the way, I just mentioned the multiple choice. And because these are multiple choice items that are right or wrong, long surgery boards, things like that, even though they used to be 1,800 items, it still takes me about 60 because they could be guessing. But here's the same thing. This person can't pass items to the pass point. They can't pass items easier than that. There's just no reason to ask them lots of heavy-duty questions. Now, we give them more items than this because I just don't want to go to a judge and say, Judge, we gave a person 4 items and they just lost 25 years of schooling. But the reality is, this person's never going to pass this test. Now, how are we doing time-wise? 15 minutes. Oh, what the heck. Okay, I need 2 volunteers. You don't have to get up. 1 person needs to be able to count to 7. Is there a person in the room and count to 7? Yes, sometimes it takes a long time to find that. You can stay right there. That's great. And I need 1 other person who can tell me a number. You just need to be able to count a number. Great. Okay, so, you're going to, hang on. You pick a number between 1 and 100. Don't tell me what it is. And you count how many questions it's going to take for me to get there. And I only had half a cup of coffee today, so I may be off a little bit. Okay, now, let's do a classical test on this. I would give you a piece of paper, and I'd ask you 100 true-false questions. Is it 1? Is it 2? Is it 3? Is it 4? Is it 5? I have 15 more minutes. Is it 6? All the way up to 100. Or I can do the following. Is your number, start counting, is your number greater than 50? Is your number greater than 25? Is your number greater than 37? Is your number, no, here's how I get in trouble. Is your number greater than 31? Is your number greater than 34? Is your number greater than 33? Is your number 34? No. Okay, and how many? 7, perfect. Sometimes I'm off, I take 8, but it should take 7. That's an adaptive test. That's all there is to it. The only thing is we have to do that seems a little off is, okay, any trait we're measuring is not exact, right? I don't know the exact depression level of 44, but the nice thing is we use a different kind of item for rating scales. Usually is, am I too tired to run an errand? Never, sometimes, usually, always, etc. So by answering that, even though you've given me 1 answer, I actually zero you in a lot faster. And I can apply that to just about any trait. So far, I've never found a trait I can't do it, but I'm required by law to say that I might not be able to do it. So, okay, let's talk about physical functioning. Want to measure physical functioning? So I know I have a range of the trait of physical functioning. I have people whose physical functioning is limited to the amount of functioning required to stay in bed. I have, I was going to say Lance Armstrong here, but that's not politically correct anymore. Okay, so we have, and I have a bunch of items, okay? And within those items, I can create a ruler of functioning across this trait. I can find items or identify items that go across the range of that trait. So now I have my CAT algorithm. Forgive the... All right, I have a person here. I have no idea this person's level of physical functioning. So what am I going to do? My CAT algorithm is going to go out. It's going to find an item near the middle of the range. I'm going to ask that item of this person, and I'm going to find out, oh, no, they're a little bit of an athlete here. So at least they think they're a bit of an athlete, but we'll see what they're doing. So I'm going to ask another question at the higher end of the range. You've got one to them, and we're going to finish off. My animation keeps going here. We know at the higher end of the range. I'm going to give them a couple more items to zero in where they're at, and when I'm done, I know. Now I've got a person, I know that they're going to be at the other end of the range to some extent. We picked from the middle, so we're going to go to the left of the range because they said they're having trouble walking around the block. We take a much easier item, and we go ahead. Now I'm going to show you looking at both people at the same time. So what am I doing? I know these people basically exist ahead of time, so after one question, I have a fairly good idea of the range they're in. I actually know exactly the percentage chance they're in this range because I've tested thousands of people. It's always possible this person said they have trouble walking around the block, but they still run a mile. It rarely happens, but it can, which is why I can't give just one question. And by the way, if you give just one question, it may be good enough. Very often we do drug research and things with a very limited number of questions. If all you want to know is the average functioning of hundreds of people, 1, 2, or 3 questions will do the job. If you want to know the clinical functioning of an individual person, it won't do the job. Okay, I can give another question, and what's happening? My error, my reliability of their measure, the likelihood I know where their real score is reduces, right? Originally, I have no idea what their score is, right? They could be anywhere 1 to 100. After 1 or 2 items, I'm pretty sure I know the range within 10 points, then in 5 points, then in 2 or 3 points. But guess what? We never have it within no points. I never can tell you with 100% certainty a person scores 33. Neither can any other measure that anybody ever gives. I have really bad news for you. You took the SAT, your score was that score, give or take 100 points. It's not your real level of functioning. People just don't want to believe that. So if you had a really high score, sorry, it could have been lower, and vice versa, you should have taken it again. Okay, so why do we care about this? We stop at a specified number of items. It turns out there's a point of diminishing returns and the level of precision. And again, for a trial where we're just trying to get the average level of functioning, does it change? We could do this with 2 or 3 items. If we want higher level of reliability, we can go higher. We used to think we had to go as high as 12, average 5 or 6. And our latest research says we can really do it in 4 items or so. Okay, so why do we do all this? Reduce the burden of responding. I hope you've seen we get there a lot faster, which means you can tack this on to some research that you're doing. You can make room for measuring more domains. So back to the instrument batteries really fast. I said 200 instruments in, and I've got only 10 minutes to do that or so. So here goes, PROMIS, this PROMIS website, and I urge you, in the hallway at the break. There are 2 brochures out there. One's the NIH Toolbox. It's a little catalog of instruments. Some web addresses in the back, and another little yellow one here that talks about PROMIS, Toolbox, and Neuro-QoL, and where to find out more information. Okay, so PROMIS, lots of things here. What's in PROMIS? PROMIS is made up by 12 research sites, 3 centers, about 150 scientists, obviously a larger effort. So far, it has over 100 peer-reviewed publications. As of last count, which is now inaccurate, 40 adult measures, 20 pediatric measures. In total, PROMIS has about 200 measures, most available in English and all in English, some in Spanish. Emails I was getting this morning, I'm sorry, was peaking, was a group in the Netherlands opening up they just translated the whole thing into Dutch. So there are about 150 languages available for some of the measures. And generally non-disease specific, although there are beginning to be some disease specific ones sneaking in. A little bit, many instruments, 1 metric, blood pressure, as we talk about it today, was taken by, I'm not the medical person here, but, we looked at diastolic, systolic, we actually physically looked at a change in the mercury level on a device. Well, guess what? Nobody does that anymore, except we use the same frame of mind, the same measurement. This is the case with these types of instruments that I'm talking about. We can give them as cats, we can give long paper forms too, but we can put them on the same measurement in the same way that I can take mercury, I can make it digitally. There are ways of taking scores so that they mean the same thing, and I don't have enough time to talk about that. Okay, PROMIS domain framework is generally one of self-reported health, global health, roughly divided into physical, mental, and social, symptoms, functions, etc. Let's dive in. Basic PROMIS banks, physical, pain, intensity, interference, fatigue, sleep disturbance. Things like pain interference and pain intensity. Interference very often is a better measure of what patients are feeling about their pain rather than just trying to quantify exactly what that pain is. Depression, anxiety, satisfaction with participation in social roles. Physical health, all sorts of things. Bottom line here, there's a catalog of these instruments, and they're very often these are domain areas that have been shown to find an effect in some kind of interventional study. So there is a good possibility that what you're studying is covered here somewhere. Without time to go through all this, but I will be around at the break. We do general physical functioning, we do upper extremity mobility. It turns out general physical functioning really covers it for most everybody. It doesn't do it though if you have a specific limb issue, so we do that. Going ahead here. And we have almost all these same instruments in pediatrics at this point. The questions are asked differently, and saying they're in pediatrics, so we have pediatric so we have adult self-report, pediatric self-report, and parent report for children. Okay, clinical use of PROMIS rapidly expanding. There are literally hundreds of such studies. Of course, Jeff Dusek's got the wrong thing there because I updated my slide. Sorry about that. Okay, Neuro-QoL quickly. 5 research sites, 12 peer-reviewed publications out earlier. It's very targeted. 14 adult domains, 8 pediatric domains, Spanish, blah, blah, blah. Okay, domain framework, physical, mental, social again, but getting more into symptoms and functions, very classically related with neurological functioning. Again, you see very similar things when we're adding bowel bladder functioning, sexual functioning, and then seeing do patients with neurological diseases answer these questions in a different way. The truth is generally not. But then we get into other things in mental health, end-of-life concerns, applied cognitive concerns, executive function. These are self-report. Everything we're looking at is self-report. We'll get into the objective measures in a minute. And also social health. Okay. So, Toolbox. Contract mechanism, 256 scientists, about 20,000 subjects. This was in the creation. We were looking at numbers. Another 17,000 subjects used it this year. Growing up, but these are domain level batteries. This is, you told me to do cognition, Richard. What do I do? Here it is. Instruments in Spanish, 4 primary domains. Okay, cognition domain framework, looking at executive function, attention. You'll notice these were domains chosen because they can be tracked ages 3 to 85. No system I'm going to show you has exactly the solution that you necessarily need without doing a little more digging, but this happens quickly. Let's see here. 420. These instruments are all available. People have been asking availability. Right now, go online, www.nhtoolbox.org, and you can get these down for web-based administration. Okay, you actually have to apply for it, but you will get but you'll be done. Right now in the field, we have iPad versions of all of these being field tested. They will be available, generally speaking, between July and the end of the year, depending which instruments you're interested in. It's just a lot less work. We have an executive attention flanker test. Has to do with how easy it is for a person to distinguish that one of the fish, what's the amount of time it takes for a person to distinguish that a fish is going the opposite direction. We have a picture vocabulary test. A person sees 4 pictures are given a verbal stimulus. They can pick from it. 4 minutes to get a completely, I don't have any idea of the person coming in. In 4 minutes, there's something like 500 items behind here. It goes to items I don't understand and goes all the way down to very simplified words for 3-year-olds. Executive functioning, set shifting, change different types of stimulus on the screen. Working memory test, a episodic memory test. We show people long sequences of activities, and then we scramble them on the screen, and the person drags them back in the correct order. Don't do this while a friend's watching you do it. Oral reading recognition. By the way, both reading and Spanish, oral reading recognition, vocabulary, and English and Spanish versions, which don't measure the same thing. Sometimes we do have to recognize that a language difference is significant. Any 4-year-old or 5-year-old can read accurately any word in the Spanish language. That cannot be said for the rest of us in this room, for English certainly. Just happens to do it, so you can't, sometimes you have to be careful. Certain traits are different. Processing speed, how quickly does it take for you to notice differences in objects? It's a 90-second test. These are tests that are given, scored, and are available for export immediately. So you just have the data at your fingertips. Motor domain, simple pegboard test. We didn't invent this, but we demonstrated its validity across the age span. They actually recently switched to our norms. JMAR, grip strength test, a balance test. Balance testing in the open market costs between $10,000 and $100,000 for the equipment. The newest version will be available as an iPod app, and it has all the equipment built into it, and you can get a full balance test. Again, it's using some of the adaptive methodologies I talked about before. You get a score. It collects 15,000 data points in 6 minutes, and then it cranks it out into a nice score. Locomotion, 4-meter gait speed test. Endurance test, we spent a lot of time. The classic test for this is a 6-minute walk test. 6 minutes was too long for us. So we went out in the field and validated 2 minutes. Turns out it's got a correlation in the high 90s, saves 4 minutes. Sensation tests, word and noise, what Nina was talking about before. This test, is not a test we originated certainly, but we'll have it available in the iPad grouping. Static visual acuity, distance learning at 10 feet. Dynamic visual acuity, important balance test. You're wearing a sensor on the head, and how do you perceive visual stimuli at a distance while that's moving? A odor identification test. We have scratch and sniff cards. They cost about $2 a piece, and you can have people go through here instead of the classic olfaction test, about $30. Taste testing, pain interference. Also, an emotional domain framework very similar to PROMIS. It's even more similar over time because PROMIS adopted things that we did and vice versa. but a quick, this takes about 12 to 15 minutes now, and you can get all of these scores in that amount of time. Okay, whoops. And I think in the interest of time, I'm going to stop. There are lots of studies going on, a fair amount of studies in traumatic brain. These instruments have been directly validated. While the goal was cross disease, they've been directly validated in traumatic brain injury, in spinal cord injury. Have some people in the room using these instruments, and they're there. And with that, I think I'm going to wrap. Perfect. Okay.